to AETCM, the emergency medicine channel. Today we are going to discuss about acute seizure management in ER as a part of our EM rapid program. Okay. So what is seizure? Seizure is any abnormal, unregulated electrical activity of the cortical neurons that results in transient change in behavior, or there can be EEG changes. So what is epilepsy? Epilepsy is a chronic neurological disorder characterized by 2 or more unprovoked seizures. And what is symptomatic or provoked seizure? These are seizure due to any identifiable cause. Okay. So what is definition of status epilepticus? So a seizure that lasts more than 5-minute duration of continuous seizure, or 2 episodes of seizure in which the patient doesn't regain consciousness, or patient will not come into full recovery in between these 2 seizures, are known as status epilepticus. Okay. So the time period. So if it is a tonic-clonic seizure, if it is lasting more than 5 minutes, then it is called as status epilepticus. Or if the patient is having focal seizures with impaired consciousness, which is known as a complex partial seizures, which last more than 10 minutes, or absent seizures lasting more than 10 to 15 minutes. These are the other definitions of status epilepticus. Okay. So classification of seizure, not status epilepticus. Generally, when we classify seizures, focal seizure is a seizure involving either a part of the body with intact consciousness, and after the seizures, since the patient was conscious during that event, even after the event, patient will be conscious, there will not be any postictal state. So that time patient might complain of thoughts, palsy of the involved area. Okay, and seizure with impaired consciousness is known as complex partial seizures. Now, primary generalized seizures. Generalized tonic-clonic seizures is known as grand mal seizures. Or patient, mostly in children, there can be absent seizures. That means there will not be any tonic-clonic movement seen. There can be lip smacking or eye flickering or head nodding movements. Okay, and other term is myoclonic seizure. Myoclonic seizure is just jerky or twitching like movement is happening, and clonic seizure is rhythmic jerky motor movement. And tonic seizure is there will not be any jerky movement, there will be stiffening of the body. Either it can be extension or flexion of the head, trunk or extremities. And another term is type of seizure is atonic seizure, that is sudden loss of muscle tone and patient might fall down. So these are the general classification of seizures. So we already discussed the definition of status epilepticus. Now what is refractory status epilepticus? So if a seizure lasts more than 60 minutes after conventional anti-epileptic drugs, like more than 2 anti-epileptic drugs were given, and if still seizure is lasting, that is known as refractory status epilepticus, and it is almost 40% of the status epilepticus is because of that. And if it is a new onset refractory status epilepticus, it can be mostly because of autoimmune encephalitis or any other viral infection, and the prognosis is bad. Okay, and what is super refractory status epilepticus? It is mainly a seizure which continues for 24 hours or more, even after giving even after sedating and paralyzing the patient, even after using of anesthetic therapy, if the patient is continuing to have seizures. That is usually seen when we start weaning the patient, we will be seeing that the seizure events are recurring. So that is known as super refractory status epilepticus, and it is associated with high mortality and morbidity. And prolonged refractory status epilepticus is known as status epilepticus lasting more than 7 days despite appropriate management. Okay, so what all are the common etiologies for status epilepticus in adults? So either it can be a neurological problem like a brain tumor, metastasis, or any infections like encephalitis, meningitis, brain abscess, or it can be because of stroke, or it can be because of trauma, or something that causes elevated ICP and cerebral edema. So these are the neurological causes. Then other causes are metabolic causes and electrolyte abnormalities. So these are hypoglycemia or hyperglycemia, hyponatremia or hypernatremia, then hypocalcemia and uremia. So these are the metabolic and electrolyte disturbances. And another ones are overdose. Can be because of overdose of something. So alcohol withdrawal or alcohol overdose can cause seizures, or intoxication of cocaine and or ecstasy. So alcohol is one of the most common cause, and alcohol withdrawal is the most common cause of seizure. Then other intoxication of the recreational drugs or cocaine, ecstasy and all can cause seizures. Then therapeutic drugs like amitriptyline, penicillin, lithium, or any antipsychotics, theophylline, or opioids like tramadol can cause seizures. Then other causes, a patient who is non-case of seizure disorder, who is non-compliant to the medication can cause seizure. And in infants and children, there can be febrile seizures also. So in children, some other causes are similar to the adults itself. Febrile seizures are there. That is one of the most common cause. Then other infections, or any traumatic brain injury, or any central nervous system malformation, or cerebral insults, cerebral palsy, any progressive neurological condition, or cryptogenic causes. So how to work up a patient with seizure? So all patients with seizures, we should obtain an IV access. We should monitor the airway, breathing, circulation, and CT brain should be taken. That is taken only in appropriate cases only. If the patient is a non-case of seizure disorder coming with breakthrough seizures, if at all required only, we will have to proceed with the CT brain. Then other lab investigations, other bedside investigations like bedside glucose to rule out hypoglycemia, hyperglycemia, a complete blood count to rule out infections like meningitis, brain abscess and all can have elevated neutrophils, so that should be checked. Renal function test, especially to look for uremia. Liver functions to look for abnormality along with ammonia. Then to rule out hypocalcemia, we need to check calcium. To rule out hypomagnesemia, we need to check magnesium and other anti-epileptic drug levels if at all patient is on any. And ECG monitoring should be done because some cardiac arrhythmias can result in cerebral hypoxia, which can cause seizure-like activity. Okay. Then continuous EEG monitoring should be advised if at all possible. Then based on clinical presentation, we might have to plan on MRI brain to look for any space occupying lesion, lumbar puncture to look for CNS infection, then toxicology panel for any suspected drugs and other relevant investigations. Okay. So EEG, when to do EEG? Ideally, EEG should be done within 1 hour. And during treatment, we need to continue doing EEG, and if at all possible, EEG should be continued till 24 hours after stopping seizures. After controlling seizures, up to 24 hours, we will have to monitor EEG. Okay, so what happens if we don't control seizures? What happens is, in the cardiovascular system, initially during seizure activity, there can be tachycardia, hypertension. But later on, there can be bradycardia, hypotension, cardiac arrest and all. So initially tachycardia, hypertension, which can progress to bradycardia, hypotension and all. Bradycardia might be mostly because of hypoxia. Okay. Respiratory system, initially because of the seizure activity or because of the compensation to the elevated lactate, patient might have tachypnea, or patient might go into apnea because of the carbon dioxide retention. And later on, patient can have apnea, time stop breathing, then patient might aspirate, and neurogenic pulmonary edema is also possible. In the renal system, initially nothing might be abnormal, but later on, if the seizure activity continues, the patient might go into rhabdomyolysis, uremia, and acute tubular necrosis. And in autonomic nervous system, patient can have mydriasis, increased salivary secretions, that itself patient can aspirate, then excessive sweating, bronchoconstriction, and hyperpyrexia. Metabolic patient can have lactic acidosis. Then initially patient might having hyperglycemia and hyperkalemia because of the excessive muscle usage. And later on patient might have hypoglycemia, then liver failure, renal failure because of rhabdomyolysis, and in the labs we can see elevated prolactin level and ammonia level. So, how to treat a patient with status epilepticus in ER? So, first we need to stabilize the airway breathing circulation. So, put the patient in left lateral position or recombinant position. Then, if at all the patient is having oral secretion, we need to suction that. Okay. So, at the time we need, then after that, that time during the seizure episode, the patient might not be having a patent airway or patient may not be able to breathe properly. So that time we need to start on supplemental oxygen therapy via nasal cannula or nasal mask, or if at all intubation, we will have to plan on rapid sequence intubation. Then we will have to attach, initiate ECG monitoring. That also should be done. And then we will have to rule out hypoglycemia by checking bedside blood sugar, and if it is less than 60, mostly we told that one of the most common causes intoxication, so we need to give thiamine along with glucose. So alcohol intoxication or alcohol withdrawal, we need to give thiamine along with glucose. Okay. And we need to place IV cannulas and connect to ECG monitoring and other hematological investigation, complete blood count, electrolytes, and toxic screening also should be sent. Then after that, if seizure is continuing, this should be done in first 5 minutes. After 5 minutes, if seizure is still continuing, then we will have to do then we will have to start treatment medications. The first line medication is benzodiazepine. So benzodiazepine usually given after 5 minutes of seizure activity. It is IM midazolam can be given if 10 mg can be given if it is more than 40 kg, or 5 mg for 13 to 40 kg can be given, or IV lorazepam can be given 0.1 mg per kg per dose to a maximum of 4 mg, and IV diazepam can also be given. These are either one of the all three should be used. So if you are using IV diazepam, we need to give 0.15 to 0.2 mg per kg per dose to a maximum 10 mg per dose, and the doses may be repeated. So first 5 minutes we told we will be stabilizing airway breathing circulation, we will be placing IV cannula, then we will be connecting to the cardiac monitor, all this thing. Then we will be starting on the anti-epileptic drug therapy, that is benzodiazepine, and any one of the three will be given. And if still after 5 minutes patient is continuing to have seizure activity, in that case we need to give we need to repeat one more benzodiazepine. So same midazolam or lorazepam or diazepam we can repeat after the 5 minutes of giving the first dose. Okay. So benzodiazepine, as we told, it is the best initial treatment, and diazepam and lorazepam are effective. Although lorazepam is having a slower CNS penetration than diazepam, the onset of action will set in within 3 minutes. So that is also good for controlling seizures. So diazepam, the advantage is it is very fast acting, but it is short lasting. It will act fastly, but it will last only up to 25 minutes maximum. Why it is fast acting is because it is more lipid soluble and it can cross blood brain barrier fast. Okay. And lorazepam, there is less lipid distribution, so the onset of action is low. So that means the onset will be within 3 minutes, and half life is up to 2 to 3 hours. Okay. And it is having longer therapeutic half life. Next is midazolam. Midazolam can terminate seizure within 1 minute. It can the advantage of midazolam is it can be given intramuscularly, intranasally, buccal. All these things can be it can be given in alternate routes, and the dose is 0.2 mg per kg, maximum 10 mg. And another advantage of midazolam is in case of refractory seizures, that status epilepticus, that means seizure lasting more than 40 to 60 minutes. In these conditions, we can give midazolam as an infusion also. Okay. If suppose the patient doesn't have an IV cannula, we have told that there are other methods, like we can give IM or buccal midazolam, dose we have already mentioned, or we can give intranasal midazolam bilaterally. So each nose, if we are giving 5 mg, 5 mg is total 10 mg that can be given intranasally. Or we can give diazepam, it can be given rectal or intranasal, doses 0.2 mg per kg. Then if the seizure still continues, so initial 5 minutes we told what all things to do: airway, breathing, circulation, cardiac monitor, IV cannula, all these things, start oxygen, these things. Then after 5 minutes, if seizure continues, we will be starting on benzodiazepine. Then after that, still after 5 minutes, if seizure continues, we will be starting, we will be giving another dose of benzodiazepine. And if still the seizure continues, then we will have to plan on giving a anti-epileptic drug. Now the second line drugs are which is usually started from after 20 minutes. Okay, so we have already told first 5 minutes we will be stabilizing the patient. Next 5 minutes, after 5 minutes if seizure continues, then we will be giving benzodiazepine. We will wait for 5 more minutes. If still seizure is continuing, we will be giving benzodiazepine again. Then after that, so it will be around 15 to 20 minutes. So after that, if seizure is still continuing, then we will have to plan on second line agents. So they are IV FOSPHENYTOIN or valproic acid or levetiracetam. So if we are giving IV FOSPHENYTOIN, the dose is 20 mg per kg, maximum of 1500 mg, single dose. Or we can use IV valproic acid 20 to 40 mg to a maximum dose of 3000 mg per dose. Or we will be using IV levetiracetam 20 to 60 mg per kg, maximum of 4500 mg per dose. Okay, so first one we've told phenytoin. So phenytoin is used to control seizure and to prevent recurrent seizures, and the serum level is 15 to 30 microgram per ml, and the dose is 20 mg per kg, and it should be given at the rate of 50 mg per minute, slow IV. And another drug is fosphenytoin. Fosphenytoin is actually a water soluble prodrug of phenytoin, and it is and it will get converted into phenytoin. So the advantage of fosphenytoin is it can be given IV and IM also. Okay, and if fosphenytoin will get converted to phenytoin within 10 minutes if we are giving as a rapid IV infusion, and if we are giving as a slow IV or IM, the effect of anti-epileptic effect will come within only 30 minutes. Okay, and fosphenytoin is better tolerated by the patient than phenytoin, and the dosing of fosphenytoin is same as that of phenytoin, but we need to calculate in terms of phenytoin equivalent. So 1 mg phenytoin is equal to 1.5 mg fosphenytoin. And another thing is there is propylene glycol in phenytoin, and that is not there in fosphenytoin. So propylene glycol usually causes cardiovascular side effects, so that will not be there in fosphenytoin. Okay, so as we discussed, the dose of phenytoin is 15 to 20 mg per kg and fosphenytoin 20 to 20 mg per kg. So 100 mg phenytoin is equal to 150 mg fosphenytoin, and extravasation and severe tissue injury will happen in phenytoin, and extravasation is well tolerated in fosphenytoin. and because of the presence of propylene glycol there can be hypotension and dysarrhythmia, and these complications are less in fosphenytoin. But the disadvantage of fosphenytoin is it is expensive. Okay, so advantages of fosphenytoin we have already discussed. It is by 100% bioavailability is there. The better tolerated at the site of injection, can be given IM and IV. Then disadvantages is it will take some time to get converted into phenytoin. Then sometimes the patient might complain of paresthesia and pruritus, which is more frequent than phenytoin, and the use of phenytoin equivalents. Okay, next is phenobarbital. The dose is 15 mg per kg. It is given at 30 to 50 mg per minute, and it causes the disadvantage it will cause prolonged sedation and hypotension, especially if we are combining or if we have already given benzodiazepine. So airway protection will be an issue. Okay, and so that this patient, if at all we are giving phenobarbital, we need to monitor cardiovascular system and the respiratory system. Another second line agent is sodium valproate. The dose is 30 to 40 mg per kg IV, and it is given at 10 mg per kg per minute. So it is having similar efficacy of phenytoin, and other drug is levetiracetam. Levetiracetam is a good anti-epileptic agent, and it is a drug of choice in patients who is having liver failure, and the peak effect will come within 2 hours, and the effect lasts for 2 days, and there is no much significant drug interaction, and the dose is 20 to 60 mg per kg IV over 15 minutes. Okay, so these are the this is the all the drugs, anti-epileptic drugs in a table. We will discuss the side effects. Side effects of benzodiazepine is respiratory depression, risk of apnea, there can be hypotension, sedation if we are using along with barbiturates. Then if the patient, if we are giving phenytoin, there can be hypotension, ECG changes during acute administration, and sedation at high doses. And if we are giving phenobarbital, there, as we already discussed, there can be respiratory depression combined with benzodiazepine, and there is risk of hypotension also. So still after giving benzodiazepine, after giving initial benzodiazepine, second dose of benzodiazepine and anti-epileptic drug, if the still seizure is continuing, that means it will be almost more than 40 minutes. If seizure is still continuing, then we will have to give the patient with anesthetic doses of medications like thiopentol, Midazolam, phenobarbital or propofol. It should be given as a continuous infusion along with EEG monitoring. Okay. So refractory, so more than 40 to 60 minutes means patient will come to a definition of refractory status epilepticus. Okay, so we are planning to start on benzodiazepine infusion. So benzodiazepine infusion, midazolam first we will be giving 0.2 mg per kg IV bolus followed by 0.1 mg per kg per hour infusion. And if seizure is stopping, continue for 24 hours, and if seizure is persisting even after 45 to 60 minutes, then change to propofol or phenobarbital infusion. That means the other drugs. Okay, and if second one is propofol infusion, the dose is 1 to 2 mg per kg over 5 minutes, and repeat 0.5 to 2 mg per kg until seizure stops. Then we can start infusion at 20 microgram per kg per minute and titrate over 20 to 60 minutes. While giving this infusion, if any breakthrough seizures happen, we will have to give bolus dose of 0.5 to 2 mg per kg bolus every 2 to 5 minutes, and increase the infusion rate, to 5 to 10 microgram per kg per minute every 5 minutes till seizure is controlled. And if seizure stops, continue for 24 hours, and if seizure is persisting, then change to midazolam, persisting after 45 to 60 minutes, change to midazolam or phenobarbital. Phenobarbital infusion, the dose is 5 mg per kg IV bolus over 10 minutes and additional 5 mg per kg if seizure continues, and infusion is 1 mg per kg per hour infusion, and if seizure stops, continue for 24 hours. So in case of refractory status epilepticus, we need to start infusion. Along with that, since we are starting on infusion, we need to airway might be compromised, so we need to sedate and paralyze the patient, and we need to intubate the patient. Okay. So the side effects of continuous infusion is, we have already told, we discussed about the benzodiazepine side effects like respiratory depression, hypotension, and propofol. There can be hypotension and propofol infusion syndrome. And phenobarbital, already we have discussed the respiratory depression and cardiovascular side effects. So as we were told, intubation and mechanical ventilation is required to maintain normal PaO2 and PaCO2, and along with that we need to give fluid resuscitation to maintain adequate systolic blood pressure and cerebral perfusion. And note that if we are starting on propofol infusion, propofol dose of more than 40 mg per kg can lead to propofol infusion syndrome. And if we are continuing more than 48 hours also, there is a risk of propofol infusion syndrome. So when all will we do rapid sequence intubation if in a patient with seizures? We have already told in refractory status epilepticus we will be doing rapid sequence intubation. Other than that, if we feel that the patient's airway is unprotected or unmaintainable, we will have to intubate the patient. Or if there is any apnea or inadequate ventilation happening, we need to intubate the patient. Then in hypoxemia, we need to intubate. Status epilepticus lasting more than 30 minutes, that we have already told. And if we need to protect the airway for any brain imaging, like in case of trauma or stroke or seizure, if we are suspecting trauma or stroke, then if you want brain imaging, then also we need a patent airway to shift the patient to the imaging room. So propofol, midazolam are excellent choice of induction agents as it is having anti-epileptic property. Drugs like etomidate is associated with slight increased risk of seizure activity, and succinylcholine can cause hyperkalemia also. So etomidate and succinylcholine are not much preferred. If we have an option of propofol and midazolam, prefer that. Always remember that muscle relaxation or paralysis of the patient doesn't mean that we have stopped the seizure. Seizure movements might be cessated, but the patient's abnormal cerebral electric activity might be continuing. So even though we have sedated and paralyzed the patient, we need to take an EEG and we need to monitor for seizure activity in the brain. And we need to continue anti-epileptic drugs also. Okay. So this is to summarize regarding acute seizure management ER. So first 5 minutes we have told supportive care, IV access, check the airway. If the patient requires suctioning, suction the airway, start on oxygen, IV access, monitors, cardiac monitor, oxygen, point of care glucose. If hypoglycemia, we need to give dextrose along with thiamine. Then check for the patient protection. Okay. Then after 5 minutes, if seizure continues, then we will be giving benzodiazepine as a first choice, lorazepam, benzodiazepines, diazepam or midazolam. If the seizure is continuing after 5 minutes of giving first dose, then we will be repeating another dose of benzodiazepine. Then after that we will be giving IV FOSPHENYTOIN or phenytoin or levetiracetam. After the second dose of benzodiazepine, even after that the patient is continuing to have seizure, we will start on any of these anti-epileptic drugs and we will consider intubation. If the patient's seizure is continuing more than 40 to 60 minutes, then that is called as refractory status epilepticus. In that condition, we will be starting on midazolam, propofol or phenobarbital infusion. In this condition, we will be anyway intubating the patient. Then we will have to admit in ICU and continuous EEG monitoring is also required. Okay. And after managing all this, before discharge, if we are diagnosing the cause of seizure as as something precipitated, if we have ruled out all the electrolyte abnormalities, all the other causes, and if it is an epilepsy, if the patient is diagnosed to have epilepsy, this patient should be started on long-term anti-epileptic drug therapy. So that is all about acute seizure management in ER. Thank you.